Hello, everyone, and welcome to today's edition of Pathcast. We are sorry for the delayed start. Sorry that you had to be waiting. Hope you all are staying safe. Today is June 12, 2020. I am Rifat Mannan in Philadelphia, and I am remotely joined by my good friend Emilio Madrigal. He is in Boston. Today, we are very excited to host this panel discussion featuring two pathologists and an internal medicine specialist and hear from them how they teamed up during some of the worst times of the COVID-19 pandemic in New York City and helped the patients and their families. We are going to learn from them how pathologists played a different but significantly unique role on the front lines of the pandemic. Our panelists today are Dr. Catherine Hockman. She is an associate professor of internal medicine. Dr. Syed Hoda. He is an associate professor of pathology. And Dr. Neil Thies, who is professor of pathology. And we just the other day listened to his amazing podcast talk on interstitium. Dr. Hockman, Dr. Hoda, and Dr. Thies are colleagues at New York University's NYU Langone Medical Center. The title of today's discussion is Pathologists Talk Daily to COVID-19 Families, NYU Family Connect. That's the name of their project. As always, please feel free to post your questions or comments on both Facebook and YouTube chat windows, and they will be happy to answer them towards the end of the session. Thank you, Dr. Hockman, Dr. Hoda, and Dr. Thies for joining us today. Over to you now.
Hello, my name is Dr. Syed Hoda. I am a director of bone and soft tissue pathology at NYU Langone Medical Center and an associate professor at the NYU Grossman School of Medicine. I really want to thank Dr. Madrigal and Dr. Mannan for having us and inviting us on to Pathcast to discuss this very unique project we started with Dr. Hockman. For pathologists getting involved in COVID-19 patients. So all of you have been affected by COVID-19 in some way. It's been a really rough, wild, and unique time for all of us. And many of us knew exactly what we needed to do at the time when the pandemic started, and many of us didn't know what to do at the time when the pandemic started. And this project started right before the peak of the pandemic. So if we could go to the first screen. So this, I put this photo up to remind you that we often don't know everything that can be done with a microscope. And there are things we don't know. And this is an actual photo of somebody in the profession of art forensics. Now, art forensics is done by using a microscope on extremely valuable pieces of artwork in order to analyze whether it's authentic, if it has integrity, if it's been modified. These people get paid a lot more than our 88305 biopsies. And I realized after looking this up, I didn't even know such a thing existed. And I found out it's actually down the street from my apartment. So one of the largest art forensics labs. So if this doesn't work out for me, I can always walk down the street and become an art forensics person. I hope that this talk inspires you to think of the things that pathologists can do that we haven't done before. There's always room to try new things and to try to push into new boundaries. So next slide. So we do have some direct communication with patients, and I put this screen up just to remind us of some of the ways that we do talk to patients and their families and get involved. For a long time, the stereotype within our field and outside of our field is that pathologists don't deal with patients, and pathologists went into pathology because we don't want to deal with patients. For myself, that's been absolutely contrary to why I went to pathology. I went into pathology because I wanted to get involved in patient care. I wanted to help decision-making for the patients. And what I've realized now, after about 9 years of being an attending, is that I really want to get involved with also family care and helping and guiding patients and their families and society in general for their diseases. So there are pathologists who get involved, and some of the great examples of pathologists getting involved are blood bank, for example, in plasmapheresis, and we all, during our training or at different times, have seen that, where we go up to the wards and help with patients who need plasmapheresis directly. Cytopathology, of course, has a wildly popular FNA clinic in many different hospitals around the world. where cytopathologists are trained even in ultrasound to detect masses and take needle biopsies at the time and do a quick assessment and talk to the patient. Obviously, autopsy deals with families of the deceased. It's something that is a very old part of our profession and a very important part of our profession in that way, in which families get a liaison through the autopsy pathologist to know how their relatives died or how their friends died. Surgical pathology is a big gap, and we have not had any kind of regular, constant communication with patients or their family members, or any kind of even educational role in that way. It's generally been the clinician who orders biopsies and who orders tests to be the interpreter of our reports to the patient. So it's not routine in our workflow by any means, and I would like to stress, not yet. There is room to explore these kinds of ideas in our vast profession. So we'd like to talk about it a little bit later. Next slide. So pathologist involvement in COVID-19. Obviously, pathology got the brunt of laboratory testing for COVID-19, and we all heard about this. Every day we were watching the news and finding a new test. Now they've got it to 5-hour turnaround time, 3-hour, 2-hour. You hear these sensationalized reports of 20 minutes, 5 minutes. And that was all done by laboratory medicine. There were pathologists running those labs. There were pathologists helping run those tests, and there were technicians involved extensively throughout the country and throughout the world. Significant. And autopsy obviously became a second role where we tried to learn about a new pandemic. Not easy. How many times in our life do we get a new infection that really grips the world the way COVID-19 did? Very few times, hopefully never again. But this was a crucial time for autopsy examinations. Surgical pathology, we had organ-based research and plenty of papers coming out and conferences about findings in the lung, findings in different organ systems like the GI tract, skin manifestations of COVID-19. And internationally, if we could go to the next slide, we had pathologists that were on the front line. So I spoke to all of these pathologists and are sharing it with their permission. You can see Laura, Seema, and Beatriz here. Beatriz and Laura were in Spain, and they were working in COVID-19 clinics directly with patients. Beatriz reading some EKGs, can you imagine? A pathologist becoming a cardiologist, because the cardiologists were likely needed in other roles too. But they were all serving the front lines. Seema in Turkey, working on the front lines of COVID care. And actually, I spoke to many people during this time who were serving these kinds of roles. And it was amazing to see, and some of you may have read the reports in Italy early saying that there were no specialties anymore at the beginning of COVID-19. All physicians, radiologists, pathologists, whatever you were trying to help out. And that spirit really hit me when I read these reports. And I'm sure it hit many of you as well. How can I help? Next slide. We did have some residents and attendings helping in the US as well. This is Raquel Yokota from Albert Einstein, who was trained previously in a non-pathology specialty, and she's a pathology resident right now, and she actively got involved at Albert Einstein College of Medicine and Montefiore Medical Center in New York. We had a fellow, a cytopathology fellow, Justin Snow, who also ended up doing night shifts on the night shifts for COVID ICUs. And there are other instances as well. So our example turned out to be a new way of doing things. And I was originally intrigued by these ICU bouts. I am 15 years out from doing any kind of critical care, but I was brainstorming day and night about how to do this. And I saw Dr. Hockman's email introducing this program, and it literally took me a matter of seconds to just respond and say, yes, I'm in. So at this time, I'm also very happy to do this meeting with my two colleagues, Dr. Hockman and Dr. Thies. And they've been amazing to work with. And Dr. Hockman is actually on with us, and she's going to talk a little bit about NYU Family Connect. So Dr. Hockman?
Dr. Hoda, thank you so much. And it's a real privilege to be here. If you had told me at the beginning of this year that I would be doing a national podcast with two pathologists, I would think I was in a different sort of time zone or different time warp. But here we are doing a great presentation. And I have to say, if there was any silver lining for me for this horrible COVID chaos that we've all gone through and hopefully trying to get the better of now, it would be, for me, getting to know colleagues who, like Neil and Saeed, we've been working in the same institution for years, but we haven't crossed paths like this. So it's been fantastic. So let me back up a little bit and tell the group here a little bit about the NYU experience. And the graph on the left is just for one of our 4 hospitals. That's the hospital that we were mainly in for NYU Family Connect. And what it shows is the number of admissions coming in from the ED, which are PUIs, patients under investigation. So you can see that as of the beginning of June here, we've had 2,500, more than 2,500 admissions just from the ED. Now, if you look at our entire system, which includes Winthrop, and there's a Brooklyn hospital and another hospital that was an orthopedic hospital, again, all these hospitals were turned into COVID hospitals. We had over 5,000 people admitted and discharged from our system. And if you think about that, and you just put it in context for a second, that is more than 36 other states. So NYU Health as a system discharged more patients than 36 other states. So it's really quite a remarkable experience. We really very much were in the epicenter. Just to give you a snapshot, we usually have, so I run the Hospitalist program, and we usually have about 8 teams running. We had to ramp from 8 teams all the way up to 42 teams. At our highest, and at our highest moment, so we peaked in Manhattan, we peaked at the beginning of April. In Brooklyn, they peaked a week later. But at our peak, we had 196 patients in the intensive care unit. That's unreal. Normally, the number would be about 18. We would have pop-up ICU units that were going on. We would pop up every day. And we had to get, again, the reason why those cardiologists weren't reading the EKGs is because they were all becoming intensivists in the ICU. All of my hospitalists really had to work in very different, models of care. So normally we're used to having a hospitalist, a resident, 2 interns, maybe some medical students, a physical therapist, a care manager, a social worker. All that went kaput. And we needed to maybe have 1 hospitalist with 2 or 3 NPs seeing 30 patients. Anyway, so it really challenged us to come up with innovative ways to care for patients. And we all became COVID hospitals. With a COVID hospital, you need a COVID army. So that was my job of trying to get practitioners from all over the institution to now come into the inpatient wards. So imagine that. I have a lot of respect for people who've been in the outpatient practice for decades that were now coming to be part of this COVID army. So just as Saeed mentioned at the beginning, everyone was innovating, everyone was getting uncomfortable and looking to ways to help. So I think there was real camaraderie in trying to get the situation under control. So this was the challenge. So when I was up on the wards, as I mentioned, we had tons and tons of patients from 8 teams to 42, very, very, very high patient volume. At the same time, us and every other institution across the country imposed visitor restrictions. We didn't want to spread the virus even more. So you put it together, the families can't visit, and the families weren't allowed to visit, and the teams were too busy to call. So you could see how this would be sort of the perfect storm for poor information and very, very anxious families. So I know that the patient relations team was getting tons and tons of calls from anxious families, and they weren't really able to address them very well. Around the time, so at the end of March, I actually happened to get sick with COVID myself. Now, I consider myself very lucky. I had a mild case. I never even made a fever. In fact, I just had a sore throat, a cough that went on for about 3 or 4 weeks, and I was very fatigued. In normal instances, I wouldn't have even gotten tested. But because we were in the middle of a pandemic and I was in the middle of a 2-week stint seeing patients, and I didn't want to infect anybody, I got the test, and unfortunately it was positive. So I spent 2 weeks then. I knew I was going to spend 2 or 3 weeks in my bedroom quarantine, and I really wanted to make the best of it. So that's why the vision of NYU Family Connect came. I was stuck in my bedroom. I was displeased with the flow of communication. We could do better than this. So I wanted to create a systematic approach where the family of every single patient, and they were all COVID patients at this time, the family of every patient got a proactive daily call. So not waiting for the family to get upset, waiting on the sofa for that call, and then calling our medical center trying to get information. No, we wanted to get a proactive daily call from medical professionals who knew what they were talking about, people who were able to give timely, meaningful information about their loved ones, and done so in a very compassionate way. So I thought to myself, how the heck are we going to get this done? Because it really does need to be done. And that's how this Family Connect team came to be. So if you look at the top here, we had, and I will say that I put the call out as Dr. Hoda mentioned, and I wanted to understand, like, are there resources here? Are there people who may not be working in their usual capacity, again, disrupted by this horrible COVID epidemic? And in addition to the radiologists, who were the first people to put up their hand, I had a fantastic showing from the pathology squad. So what we did was we paired all the attendings, and again, in addition to pathology, there was radiology, neurology, dermatology, orthopedic surgery, urology. So I had a bunch of different attendings, fantastic attendings, who put their hand up and said, we want to help. How can we get involved? And we paired every attending. So a pathology attending would be paired with a medical student, because again, the medical students were not allowed to come and take care of patients directly. That was a rule from the dean. And so I said, okay, how do we get, usually the frontline team would speak directly to the family, and you wouldn't need any more of these little boxes. But now it said that wasn't the case. So we made the pathology attending and med student sort of this like intermediary. And they were kind of like air traffic control. So I'll tell you what they did in a second, but they were the ones who were interfacing with the family. They were interfacing with the frontline team. They were interfacing with an on-site nurse who was able to FaceTime the families. They would interface with the call center. So we created this great lattice work. And again, it was a workaround, but it was necessary because we were not, as a frontline team, able to call the family directly. So let me get into that a little bit more. This is the problem we were reacting to. So here is a situation, in this case, the family is calling the call center. And this might be, in addition to the phone calls that we made every day, the family would be the call center would be getting tons of calls from families. So this is the original problem we were trying to address. And here's how we solved it. So the pathologists and the medical students were each assigned a group of patients. And the call center would know, because we had a great, massive schedule, and we were really lucky to have two fantastic operations people who were helping us out, Jaya Sandi and Rachel Ramsey. They really created the schedule. So the call center would know exactly which attending and medical student would be in charge of which patient. So if they got a call from the family member, well, they would quickly secure chat, which is a way that we communicate with ourselves via Epic, which it's like a text message. So the call center would secure chat the appropriate pathologists and medical student. Then the pathologist and medical student would call the family and answer the questions. All this would be documented in Epic. So let me get to the proactive part of it, because I think this is where we really made an impact. So there were 4 parts of this proactive daily call. And again, when I created this sort of vision in my bedroom, we really needed to kind of break it down into these 4 steps. So just like any intern who's on the wards, physically on the wards, you have to know your patients. So the first thing that I did, and we did these training sessions with all the pathologists on the line, and that was one training session, and then I had med students on a different session. And we would teach everybody how to look for key pieces of information in the chart. So we would log into Epic. We had a great IT team that created what was called the COVID-19 summary in Epic, where it was like sort of one-stop shopping, where everybody could get every bit of information on the COVID patient. So for example, all the vitals, but not just the vitals, of course, the oxygen saturation and how much oxygen that person was receiving and in what mode. So you would know if someone was on 100% non-rebreather and they were getting better or worse. So again, and I was very rigorous, make sure you write down notes, have one sheet of paper for each patient, keep yourself organized. Again, going back to the vision, the worst thing you could do is give bad information to the family. I personally think no information is better than bad information. So you got to keep your facts straight. The second thing is we created, again, via technology, a way to call into interdisciplinary rounds. And this gave the Family Connect team a way to listen and to ask questions for the frontline team. So again, the goal was to give good information. So number one, look through the chart, know what you're talking about. Number two, listen to rounds and ask questions. And then and only then, number three, would you make a call to the family. Now you can do so with confidence because you've listened to the rounds and you've performed a good chart review. The calls were scripted. It was something like, hi, I'm Dr. Catherine Hockman. I'm calling from NYU Family Connect. May I please speak to whoever the healthcare proxy is? Again, you want to make sure you're speaking to the right person. Once you get to that person, you could say, I would like to give you an update on your loved one. And again, here I am about the New York Times headline. Don't get into the nitty gritty. Start with the first sentence. Your family member, your brother is getting better. Again, New York Times headline. Don't get lost in the weeds. And then you say why he's getting better. Well, he's on less oxygen than when he was yesterday. And then what's the plan for the day? The plan for the day is that he's going to be moved to a less acute setting, and you're going to get a call from me tomorrow. Now that's the script. Now, just like, we're not all robots here. Every patient is different, and all family members are going to have different questions. And things are things can be very personal. When we made some of these calls, and Dr. Hoda and Dr. Thies can speak about this in a minute. Sometimes we realize that the person on the other end of the call was also sick, and that they might need to be going to the hospital. Or, sometimes that other person had so many intricate questions that perhaps the Family Connect team didn't really know the answers. And that's okay. I always tell my team, if you don't know the answers, that's fine. Don't make it up. Just say, I'm going to figure that out and I'll get back to you. And that's what happened. And then the last thing is we documented an epic. And this was a care coordination note. We did it. If you type in the .fam update, you would get to this note here. And this is a very excellent note. This one was actually written by Dr. Thies. And you could see we blanked out the names. But you could see we discussed the clinical update with the family. And we talked about how the patient was going from very prone to supine position, and he tolerated better. He got a bronchoscopy. Again, the clinical plan and what was documented. These notes were so helpful to all members of the team, which is something that I don't think we really anticipated when we started these NYU Family Connect. These were read by all members of the team. It was a quick snapshot. It told the team who was the person who was caring for, who was the healthcare proxy, and more importantly, like what their thinking was. How are we going to get this person home safely? This is a graph that I am exceedingly proud of. We launched NYU Family Connect, so just to give some coordinates here. So the x-axis, of course, is time, and the y-axis is the number of daily notes written every day. So we plotted this out every day. So I launched the program with a radiology squad on April 6th. Just a week later, we added the pathology squad. And that was really important because with just the radiologists, we really were only covering the floor patients. What we really needed to cover was the intensive care units. And again, I mentioned at our peak, we had 196 patients in the ICU. The blue line on the graph is the COVID-19 census. So you could, and the green line is the number of notes. So you could see, again, within just a couple of weeks ramping up, we were able to pretty much mimic the number of calls to the number of patients. So that tells me that every person got a call. And sometimes people got more than one call. You see the green line is over the blue line on a couple of instances. So we had just a fantastic response. We had at one point 340 patients calls made per day on average. And of course, that went down by time as the number of patients went down. You can see the breakdown for who made the calls. So the students made about 40%, physicians 40%, and nurses 10% roughly. So these were a fantastic use of resources for people who normally would not be working in the way that they normally do. It really took a lot of courage to do this, I have to say. Again, Syed mentioned at the beginning that, normally surgical pathologists are not speaking with families on a typical basis. So to get this group of, this team trained up in really less than 5 days to be looking through an EMR that they were not used to looking at. This EMR, the pathologists did not use this EMR. They had their own separate system. So to be looking at an EMR, to be speaking with the frontline teams who they didn't know, to be calling families that they're not used to, and to be documenting in the EMR that they've never documented in this particular EMR in this particular way before, was an enormous lift. And the fact that we were able to do it, and not only do it, but knock it out of the park, is something that I'm exceedingly proud of and will be for a very long time. Just a quick, so here we did a survey, and I'm sorry, I should have put the number of survey participants here. So we had about 80 people or so from the frontline staff do a survey on how they viewed Family Connect. And the question here is, did the Family Connect program allow the frontline teams to actually focus on care? And the answer, of course, is strongly agree, overwhelmingly strongly agree or agree. So Family Connect had an impact on the frontline teams because they could actually focus on their patients. The second thing, did the Family Connect program care coordination note provide value in caring for patients? Again, strongly agree to agree. And there was one other here. Oh yeah, that's it. Okay. I'm not going to read these testimonials. We had testimonials from patients' families, from medical students saying it's been like one of the most formative experiences of her career. For my own team, Jen Wu, one of my hospitalists, said that this Family Connect team allowed her to care for patients in a more comprehensive way. The senior director for social work similarly said that allowing Family Connect paved the way for meaningful conversations with the families and allowed for better safe discharges. So the takeaways, again, number one, our mission was to provide family members with a timely, relevant update on a daily basis proactively for people who knew what they were talking about. We wanted to support our patient experience team because they were getting inundated by calls, and those calls dropped off. We wanted to make sure that the teams, again, were spending direct time on their own patient care and not worrying about having to call families. Very important. And I'd love to say that we did support our educational mission by providing meaningful clinical experiences to medical students. I think I'm going to turn it over to you guys again, and I'm happy to continue. And I actually maybe what I'd like to know, and we were going to make this a little bit more interactive, but maybe I could ask Neil. Neil, what was it like, getting trained up in 5 days, sort of remotely, in EMRs that you were not used to, with families that you normally, didn't speak to? What was that experience like, if I could ask?
Thanks, Kathy, and thanks for having created this. It was terrifying. Everyone, I think, had some degree of high anxiety, all the pathologists, and we would speak to each other by WebEx throughout the whole process too. So I had arranging calls so we could speak with each other and support each other in going through this. I think everybody had different things that were more anxiety provoking or less, though there was no piece of it that didn't come along with some anxiety. For me, the worst part was learning the EPIC electronic medical records program, because it's a vastly complex thing. Up until we are now getting ready to convert to the pathology version of that to fully integrate. But prior to this experience, all I ever did in EPIC was go in and look at an endoscopy report or a patient history summary to back up, to get clinical information and reviewing white biopsies. And now I had to go in and learn the details of how to not only investigate things, but to use parts of the program I didn't even know existed, and to write notes. I'd say the 5 days of training, that's the week of EMR training. That was the week where I couldn't sleep. I had terrible nightmares. I was waking up with high anxiety about what I was going to face in the morning, because it just seemed like this giant octopus that would be really hard to wrestle. But by the end of the time, and I think, Kathy, you probably had experience from your radiologist from the week before of what tools might be helpful. And you gave us these flow sheets that once we had gone through the training, the flow sheets made sense. And every single time I went into the records, it got easier and more intuitive, simply from things like remembering where the button is I'm trying to click on the form. So that was one. Number two was learning all this infectious and respiratory ICU care in a way I haven't contemplated in a long time. I focus mostly on GI endoscopic biopsies and liver disease. And if I had been thrown in looking for liver information in an ICU chart, I probably would know how to find that and recognize what I'm looking for. But now I have to be looking for all sorts of details regarding ventilators, with all these arcane abbreviations that I wasn't familiar with. And like Syed said, I graduated medical school in '86. So there's all sorts of words, drugs, machines that didn't exist the last time I contemplated such things. But that actually came on board pretty quickly. And though that was my second point of high anxiety, calling the patient families, for me, that's sort of how I function as a pathologist in my general world. I'm always the point person for 30 years for family and friends. When they've got a question, they call me up to say, what should we do? Or can you interpret this? Or what's the next step? So I'm used to that. That doesn't really bother me. And I think that's a primary aspect of being an academic pathologist is I teach. So whether I'm teaching a medical student, an intern, one of my clinical colleagues, or a family member, or a patient, to me, those are the same thing. But to be asked questions by the family members, we were coming in the beginning to families that had already been seeing their their family member go through whatever they've been going through for days, if not weeks, well over a month in some cases. So they already knew jargon that I didn't know. And the first call I remember making, and they said, well, what's the PEEP value last night? And I was, what, in my mind, what's a PEEP? I had no idea what they were talking about. And that was the most acute anxiety I had. It was a total flashback to medical school, being caught on the floor, being asked a question by someone who knew the answer, who knew more than you, waiting to see if you knew. And it was a real push to do my due diligence about getting up to speed on all these technical terms. And we asked each other. I think that one I actually called Syed and said, what's PEEP? And then he pointed out where in the chart it was, and I went online and I did some textbook stuff, and I learned. By the end, the flow got much better. And I would say there wasn't a tremendous amount of anxiety at all in the subsequent weeks. And just the gratitude that there was something positive to do in the midst of all this, rather than just sit and watch from the sidelines. So yeah, there were moments of very, very high anxiety, but the reward for pushing through that was profound, remains profound. Syed, you probably overlap with me to some extent and probably differ in some way.
Yes, thanks so much, Neil. Beautifully said, and Kathy for that amazing kind of summary of this innovation that you came up with. And I've been in awe since the beginning of how you developed a completely new system out of scratch, literally nothing, in a matter of days. And it was amazing to watch. And for all the pathologists out there, we all have felt the way Neil was describing. and I did too. And I would actually stay up late at night wondering, like, what can I do here? What can I possibly do? Am I going to be one of those memes where they show some, Kermit the Frog intubating, getting ready to intubate a patient? Is that going to be me in the next week or two? So I was really disrupted by these ideas of how can I do something. And it was something Neil said really importantly, is that we all went through this stuff at some point, and it may be years ago or it may be 6 months ago, but it is in our system of education that we learn how to care for people, and pathologists do that as well. We do it in our own way, the same way radiologists do it in their own way, psychiatrists do it, and hospitalists do it. But we do it in our own way, and the trick here was to try to translate this into a new experience and out of our comfort zone. And I've always had this thing in my head that some of the greatest and most real comfort arises out of discomfort. And I try to subscribe to this idea and not run from discomfort. And part of the thing was when Kathy, like Neil said, we were overwhelmed by information when we started this. And I think Neil understated his worry about the EMR situation. Because within hours of us doing a brief overview of how to write a patient chart, I was inundated by text messages saying, I don't know if I can do this. I don't know if I can actually do this or not. And we were really out of our discomfort zone. So thank you so much for that. Can we just move it to the next screen real quick? I just want to give an idea, a feel for what this logistics looked like. So we did get 20 surgical pathologists, and I have to be honest, when I said yes to Kathy in the beginning of this, and my chair and vice chair said, hey, why don't you do this lead? I was ready to just be the only pathologist if nobody else volunteered. I was ready to do that. But we had people from every subspecialty. We have one renal pathologist, and she was super enthusiastic about getting involved. We had people like Neil, who was the world expert in liver pathology, immediately ready to get involved. We had our autopsy person getting involved. We had myself getting involved, and we were all very specialized people in a large academic center. And I got to tell you, the feeling of people getting excited to jump into this discomfort zone really inspired me as well. And I think we inspired each other. And this is a 7-day-a-week thing, all weekends as well. And we split up into separate ICUs. So we would put 4 to 6 pathologists in one ICU, and they would be allowed to create their own schedule of how they're going to cover the weekdays along with the medical students. And I got to say, medical students, we have an amazing medical school that people like all 3 of us teach at the medical school as well. But I actually underestimated how good the medical students are. They were amazing throughout this entire experience. And I know some of the attendings thought, oh, medical students, talking to COVID families, like maybe they're not ready for it. If anything, I learned myself a lot more from medical students. These are really freshly trained, freshly learned students from a really top medical educational program, and they really didn't disappoint. They were outstanding. So next screen. So Neil summarized this already. These are the things that were new for us as pathologists. Basically, every part of this was new. And this photo, actually, I love this. If any of you have the courage to watch this, because I am scared of heights. There's an amazing climber in the Ukraine. He's on a channel on YouTube called Mustang Wanted. And if you're scared of heights, I just want you to spend 2 minutes during don't do it during lunch. Do it before lunch. Go and watch 2 minutes of Mustang Wanted. He is not secured by any means. He has no safety equipment. He's just a little skinny 20-something-year-old guy that climbs the craziest buildings in Russia, in Asia. He travels just to do this. I just wanted you to be aware, and also just know that that's how we felt, that photo. We were out of our comfort zone completely, but it is a rush. It is an adrenaline filled situation. I recorded a diary documentary for a filmmaker, and I watched those diaries that I made every day of the first day I was going to do this, and I looked very shaken for somebody like myself. And we all know each other, we all know ourselves. And I looked visibly shaken walking into the first day of doing this. So all of this was new. And next slide. So this is a concept I really want to hear Neil's thoughts about it. And we are diagnosticians, surgical pathologists. We get a biopsy. It's an important biopsy. We put it on our microscope. We see what it looks like. We look up the patient's chart. We see what the history is, what the current situation is, what the imaging is. We diagnose each case that we get. I had to think pretty deeply into how can my mind actually go into this kind of a duty where I walk in every morning with an entirely different set of goals. And I created this idea in my head that I'm diagnosing each patient's day. And my guess is that these are some of the nuances of somebody like internal medicine. Somebody like Dr. Hockman may hear this and say, diagnose each day for the patient. Like, isn't that, that's what we do all the time for these patients. But for us, it's a little bit different. We don't have the patient walk into our office and then we have a chat with them and see how that's going in real time. We generally have a delay of a couple of days before we look at a case, and we're moving in a different time and space when we diagnose. So I thought of this concept as diagnosing each day. So I walk into the hospital. I actually went to the hospital every morning just to put myself in this state. And we look through the chart, we call the ICU. I'm trying to formulate a diagnosis of, is this patient getting better? Is he getting worse? Is she getting better? Is she getting critical? So these things went into my diagnosis of the day. And it wasn't pathology, but our minds still work in that way, that I want to solve a problem. I want to create a dialogue of what's going on with the patient, the same way we do when we make a diagnosis. So I'd really love to hear Neil's concept about this. And also, the discomfort thing was a real thing. This was a very uncomfortable experience for some of us in the beginning. But what's remarkable is over the course of the 7 weeks we served, I felt, and Neil can chime in on this too, I felt such a change in my comfort level doing every component that we mentioned, like hanging off the building, felt more comfortable. So Neil, how did you approach each specific day when you walked in to do this?
Yeah, I really like the way you're describing this. The basic routine for me, and I think it was sort of similar for everybody, is you get up in the morning and you start going through each of your patients' online records, what notes were written, checking lab values, getting the overview, trying to put together as much as you can so you're an expert in the story already before you call in for the WebEx-based rounds. And then, for our ICU, you and I were together, it started at noon, and so we'd all log on before, and it was really kind of great watching the colleagues. I think there were maybe 6 of us for that floor, watching the pathology names pop up as we all got ready for rounds, and this feeling of we're doing this together, and that it was a team. And then to hear the floor, sometimes they were speaking directly to us, and more as time went by, they got used to us being there and were giving us really pithy sum-ups for what's going on, because they understood now why we were there and how we could help. But even so, you'd hear things going on in the background, or something would erupt in the middle of rounds needing their attention, and suddenly you are in that high-intensity ICU medical moment. And then that comes to an end, and it's time to call the families. And so one by one, working through those. And that was a little bit like surfing. Some families required very little. They were just grateful. Everyone was grateful. But they just wanted to know what the next information was, no questions. Others were managing their anxiety clearly by keeping track of very tiny details, and they expected to hear those details. But we had if they asked a question, as I said, I was terrified of not knowing the answer. But once I learned the terminology, I'd say, oh, hold on, let me go back to the chart. Or if it was something that I couldn't answer, we had the means to connect them directly and lubricate the flow of information. I had one patient that had an issue with their elderly family member this happened all at a time when they were thinking, independent of COVID, that it was time to move into assisted living. So there was a very complex social situation at home involving elder care issues. And so I reached out to the social worker, who reached out to them. And then we made a little team helping them work through those things. So we were there to be ready for, just about anything. But We all have ways of organizing information in our heads to function as clinicians, regardless of what kind of clinician you are. Over the course of medical education and years of practice, you sort of know how to put information together. And once you get comfortable with the nature of that information, the mechanisms are kind of the same. So the way I can walk into a liver transplant clinical conference, and I don't even have to think about where in my brain to put the pre-transplant patients, the post-transplant patients, what are happening to is there rejection going on? Is there recurrent disease? It all just sort of sorts it out because I'm used to that. I had to build that framework for this, but once I had the framework, which I had, I'd say, within a few days, then it started becoming easy because it was the same skill. And like I said, I'm used to having residents or clinicians at my microscope looking at slides and figuring out, okay, I'm taking this in and now I understand it. Now, how do I communicate it? It's the same thing. Calling a family, it's just maybe their anxiety state is different because of their personal involvement with the patient. But the skill set was sort of basically the same. We're all physicians. There are commonalities to that. Why we went in to wanting to do clinical medicine and how we manifest that in each of our specialties. So I think it became more comfortable. But the other thing I would add in is I'm very comfortable in my profession because I feel comfortable in my expertise within liver pathology. I'm very comfortable when someone says, could you look at a skin biopsy, and going, no, you really should take that to a dermatopathologist. I've got a neuroscience question. Well, really, no, go somewhere else. This was a situation where we couldn't triage out. And everything we were doing, we now had to rise to the occasion of being as expert as possible. And the clinicians we dealt with on the floors, and the families too, I think, on both sides, understood what an odd situation we were in and were helpful and accommodating and understanding about that.
Kathy, thanks so much, Neil. Amazing, and your wisdom is something I always enjoy hearing about, as you know already. I really want to ask Kathy, and I'm sure many pathologists probably wondering this: how does it feel to be the director of Hospitalist Medicine, and to have 20 pathologists that you're now putting out onto the quote floors to deal with patients? Because as a pathologist, that idea gives me anxiety in itself. So I would love to hear your thoughts about that.
Thank you, Saeed. And I'm chuckling because, yeah, it sounds kind of like a crazy concept. But as you both have been alluding to, this was a very different time where we had to absolutely think outside the box. We couldn't hand it over to a different specialty. We actually had to get the job done. I was thrilled, Saeed, when you put up your hand, so with such alacrity. I was thrilled. And then when you had 19 other people join you, I was like, my goodness, I'm onto something. Because honestly, I didn't really think that this would be something that the pathology squad would really want to participate in. So just the very fact that 20 people from the pathology department, were eager to participate in something they knew zero about. And P.S., we were kind of making this up as we went along because we didn't have really any experience about it. I really had such respect. I mean, such hats off, because I knew this was, akin to, I think when we were joking about this yesterday in preparation for this talk, me going down and doing like a frozen section in the surgical suite. I mean, it's crazy, an absolutely crazy concept. So hats off to you guys for really, doing this again with such alacrity. I think of this group as a very aspirational group, very earnest, really wanted to do a good job no matter what it took. And I could see And again, I was lucky to have conversations with several members of your group, especially when there were little hiccups in the road. And people would say, hey, what do you expect? And I remember there was one person in particular from your team who was dealing with a family member who herself was sick. So imagine this. Now, like, that's another layer, right? Not only did I throw you into the arena to deal with a patient in the hospital and calling the family, now the curveball is, well, now the family member herself is sick and doesn't want to go back to the hospital for various reasons. And the care that this pathologist had for this person, this family member who wasn't even a patient in our system, was absolutely inspirational. And how there were multiple calls and such thorough documentation and really great contingency plans laid out, like, if this happens, then do that, if this happens, then do this. It just, again, it gave me a little bit of an insight into how you guys are thinkers in your own profession. Again, such big picture understanding, and then like real detailed sort of analysis, and really getting the job done. So I have, again, just I sort of regret, I've been in NYU now for 20 years, and I do love going down to the pathology labs, and I do make it a point to go down with my teams and talk to pathology. I always love doing that. But we've sort of missed out on a different type of our experience, which now I'm really thankful that we can start up again at this. But you guys are great thinkers, great colleagues, aspirational group of people, very earnest, and willing to sacrifice your comfort for the greater good of our institution. So again, very proud to be part of a group with you guys. And hopefully, Saeed, you're right. Hopefully we change this trajectory in our relationship, internist, pathologist, and also perhaps how pathologists, speak with patients, because I think you guys have a lot of potential.
That's amazing to hear, Kathy. The feeling has been totally mutual. I know Neil and I talked many times about how we were just, in awe of the way, your hospitalist units and the ICUs and the CCUs were handling all of this in a totally new time. It was amazing for us to watch, and I think it inspired us back as well. And one of the great things, and I think you mentioned this early in your presentation, was one of the great positives that came out of such a negative time was the ability to connect to people in our own hospital that we wouldn't normally have, connected with in this type of way. I mean, I may have called you once before about a patient who needs a discharge and has a result pending, but it wasn't to do in real time with how to modulate and affect patient care on such a large scale. So the feeling was very, very mutual in terms of admiration.
Do we have, how are we doing for time? Because there's something I'd like to bounce off of from what Kathy said, but I'm not sure if we have time yet.
Yeah, sure. We do have. Please.
Okay, I'll try as to be unusually concise. What you were talking about, Kathy, in terms of that particular pathologist and the care and detail. The three of us spoke about this yesterday when we were getting ready for this presentation. What pathologists do is largely invisible to most of our clinical colleagues. And to us, we're all doing the sort of same thing. But there's a way in which pathology practice is kind of different from almost all other clinical practice, in that when we make a diagnosis on a biopsy, every resection specimen we see, potentially at least, becomes the single decision point out of which the future of this patient's care flows. And if you get it wrong, then the future is wrong. So we can't ever, there's no balancing where if you miss something on a physical exam, you might catch it next time, or someone else who's going to repeat the exam will do it. You make a call on radiology, but the clinician's going to take that and interweave it with clinical data and laboratory data. So there's a safety net in decision-making for the rest of clinical medicine. But for pathologists, there's no safety net. Frozen section, is this cancer or not cancer? The limb comes off or it doesn't. And so bringing that kind of attention to detail, we sort of don't give ourselves credit for what a responsibility that is, because it's just what we breathe daily. But when you put that in the context of this kind of clinical effort, there's always, should I get a deeper level? Should I get another special stain? Should I get another consult? I'm not sure yet. Let me call the clinician. Let me cut more tissue. We're constantly shaping things to get to that final report, which has the most precise linguistic statement of what things are and what the meaning of that is. That's our practice on every single biopsy we see. A couple of days ago, I think I saw like 200 GI biopsies in a day. And every single one of those got that sort of care. Fortunately, the vast majority were really simple. But so what you were seeing, Kathy, I think was the natural expression of what pathologists do every time they pick up a slide and then get ready to prepare to write their report. And I'm really proud of what we do. And it's usually invisible. We don't see it because it's just our ordinary day. And no one else sees it for the most part because they just see the report, what the product of that is. So I'm really proud to be a pathologist. I'm really proud of what we do. And I think it's a special culture within medicine. And it kind of thrills me to have someone like you, Kathy, look and go, oh, hey, wow, nice to meet you.
Everything Neil said, and I want to kind of close out our discussion by discussing something that Kathy said, that she just said that pathologists may have a role here in continuing this patient conversation, and we've seen many different isolated projects come out from various people about I've heard the quote invisible pathologist, or sorry, I'm saying the visible pathologist, and etc. But I really saw a huge amount of potential here for us to get more involved in patients' care directly, and patients' discussion with the families and pathologists. And I personally feel very strongly about this issue. Yesterday, when Neil and Kathy and I were discussing this, Neil told me about a time in the 1980s during the AIDS situation then, where patients were coming in to see and talk and discuss their biopsies with pathologists. And I had no idea that this ever happened. But what I don't understand is why we never expanded this side of our things to get into the daily workflow. And it's a challenge that I'm posing to the listeners of the Pathcast and to all of my colleagues in pathology, that are we going to step outside of our comfort zone further to expand the field for not just our own sake, but for the sake of the patient? If I was a patient and I got explained things in detail the way that I know that pathologists can do, I think I would feel better about my disease. And maybe both of you, Kathy first, you can chime in on if you feel that you deal with patients all day, every day, and do you feel that patients would benefit from that kind of an interaction?
So absolutely. My job as an internist, again, is to get all the information from all the different specialists and collate it and package it in a way that the patient understands and present it to him or her such that they understand the risks, benefits, and alternatives of every possibility. That's really what patient-centered care is all about. Very different from years ago when we had sort of a more paternalistic approach and a doctor would say, this is just what you should do. But there's something about, so again, as Neil mentioned, if you have a diagnosis, everything flows from that correct diagnosis. So having a pathology, an expert, talk to a patient about, like, this is the diagnosis, this is what we saw, and this is now kind of like what we need to do from here. To have an expert do that would be exceedingly, I think, comforting to the patient. I mean, again, depending obviously on the news, even if it's bad news, like, you would want your expert opinion. So I do think that there is a role here. I think that having Neil as the expert liver pathologist in the nationally in the world talk to me about a diagnosis, I think that would be very powerful, because then and you have confidence that all the other stuff that flows down would be in your best interest. So I do think there is a place. I really do.
And you go ahead, Neil.
Yeah, and it's not simply the teaching or conveying of information. You know, I've generally over the course of my career have made it clear, both family and friends who have had biopsies or operations, but my clinical colleagues with whom I'm really close, anytime they want to see the slide, come look at the slide with me. And I remember one particular example. A friend of the family, a woman who had colon cancer, and it was done at my hospital. And I said, "Would you like to see your specimen?" And she came up and looked at what was left of the specimen after it had been grossed, but it was largely, you could see it. And then I showed her the slides, and she goes, "That's not what I thought cancer looked like." And I said, "Well, what did you imagine?" She said, "Well, I don't know. It just sort of in my head was like this black cloud inside me." But it became this concrete thing, both physically at the gross level, and then under the microscope. These are good cells, these are bad cells. And the way that allowed her to visualize and conceptualize what was happening was a huge shift in her participation in her care and her imagining of what are the treatments I'm getting, why am I getting them, and will I respond to them? But the thing you pointed out, Syed, at staff meeting, I think like a year and a half ago, 2 years ago, is that imminently, if it hasn't already started to happen, our diagnostic pathology reports are now going to be readily available like any lab test for a patient to see. And as that happens, patients will be calling us. They will see our name on the report. They will get our phone number from online, and we will get calls like that. And we're going, whether we want that role or not, it's inevitable it's going to start to happen. And we're going to have to get the training to, like, how do we document those interactions? Because they're patient-doctor interactions. They need to be documented. They can't be casual, as I've done it for the last 30 years. So it raises all sorts of issues that I know are your greatest interest right now in some respects.
Yeah, I just want to add one thing. I know that we're on time as well, but exactly what you're just talking about, there's two things I want to say. One is that an amazing example of a call I got recently by a patient who had a very mundane, benign lesion of the soft tissue. And I had already signed out a report. He saw it in his chart on his phone, and he read it and said, "Where's the microscopic description?" And I said, "Well, we don't really write a microscopic description for every, small benign thing that we get." And he said, "But I really want one." And I said, "Well, I can do that for you." And he said, "You also didn't submit it entirely. So how do I know if the rest of it doesn't have cancer?" And I thought about this for, quietly for a minute on the phone. And I thought, and he told me he hasn't slept in 2 nights because he didn't submit it entirely and he doesn't have a microscopic description. So you know what I did, Neil? I submitted it entirely for him, the most mundane, benign entity, and I wrote him a microscopic description. And he called me the next day and he said, "I would love to take you out to lunch. I would want to take you out to dinner. You've made me feel so much better. And just talking to you has made me feel that this isn't cancer." And it was the most mundane, benign thing. And this communication, we take it for granted how much power we have about people's not just physical health, but mental health as well. Creating this, just everyone being aware of this, puts us back into that world of being patient-centric physicians, which we are. And I just feel that we don't talk about it as much. And the last thing I want to say, Neil, exactly what you were talking about. I had a pathologist in the middle of a staff meeting stand up and tell me that it's illegal for us to talk to patients on the phone. So there is a misconception in our culture, and it's not illegal, obviously. But there was a rule many years ago that pathologists could not report a lab test directly to the patient without the clinician knowing. Since our world has gone way more complex in medicine these days, so those rules are not existent anymore. But there's a cultural defect present in our field, saying that that's not something that we do, and it's going to take years of us saying that is something that we can do in order for us to get back on board with that feeling. So. And I think we're running out of time, and I just want to say that Dr. Hockman and Dr. Thies are two of my favorite pathologists, and are not pathologists. Dr. Hockman, you're not a pathologist, internal medicine, but
we'll make you one if you want to be.
I'm just so happy that we got to present this together in this way, and to thank both of you for the amazing thoughts that you have.
Syed, it was a sincere pleasure. I really mean it. I'm changing the way I think about my practice in pathology. So it's been an eye-opener, a game changer for me. So thank you.
Yeah, and you guys are awesome. The whole thing has been awesome. Thank you.
Thank you, everyone. I think we have a few questions online. I will pass them on to you. So there is one question from Emmanuel. He is watching from Philippines. He wants to know, what is the future of NYC Family Connect? Seeing this could be an amazing avenue for learning for medical students, as well as means of communication for the family of inpatients.
So thanks for the question, and that's really been on our minds as well, especially as all of the attendings and soon to be the medical students are going to be back to work. I think there is a place for Family Connect. I think what it exposed, this COVID epidemic exposed things that were already kind of frail, like healthcare disparities. But what I think that it exposed for me and my team is that we were pretty good speaking to the families, but we weren't. I wouldn't give us an A+. And I think we need to build in systems within our team, like special roles with scripting and training and all the stuff that we did with Neil and Saeed and their teams. We need to do that on the inpatient team, such that families will still feel connected. Now, many times the patient has a family member at the bedside, and I sometimes go through the whole long explanation of what's going on, blah, 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 only to find out that the healthcare proxy was not that person, and then I have to go through the whole thing again. And that, then maybe next time I'm not super eager to go and talk to the person at the bedside. So I think we need to, again, streamline communication and make it more of a priority. I mean, it was a priority on the wards, but it wasn't as rigorously done as we did in Family Connect. So the short answer to your question is, I think Family Connect has to be built into the team model, but much more sort of rigorously than we do it right now.
Kathy, do you think it could be a required rotation for medical students?
I do. I think that right now we have a clerkship, the ICU clerkship is rotating through. I think it would be a great idea for first or second years to kind of get the flavor of the team.
Yeah.
And to figure out maybe that could be part of this, like a structured part of the structured team model. But I do, again, it exposed frailties, and the frailties, we weren't really doing a great job connecting with families.
So there is another question. This time it is from Arvind Rishi, who is a good friend of mine, and he's in New York. So his question is, as the sleeping giant of surgery and clinical service grows up, how pathologists can continue contributing in person? And he adds, as of now, the desks are full of slides again. How can we continue it?
Can I just say that, hello, Arvind. I know Arvind as well, really well, a great pathologist himself. We don't realize that pathology in many ways evolved directly out of surgery. The first pathologists were all surgeons. And the origins of the frozen section was a surgeon working on a case and walking over to the corner, probably with a cigarette in their mouth in the 1800s, and doing a frozen section on the patient that they have on the operating table in the room, and then walking back with a diagnosis. So we sometimes forget that we evolved out of surgery in many ways, and in internal medicine or out of other fields in medicine. Pathology is not that old of a specialty. And with that in mind, I think that there are so many ways that we can go back, and we don't have to become surgeons or internal medicine hospitalists, but we can channel some of those parts of our training and our inherent ability back into doing some of those things. And I think just keeping that in mind and looking for opportunities in that way is very important. And one example I just want to give you guys, and this is not a scientific one or a patient-related one, even, it's a cultural one, is that when they're recruiting like oncologists that we work with, are we involved in recruiting that oncologist? No. Often we're not, but we can be. So, you know, like that's a small way we get involved, but just by getting involved in, and I've done this in my own practice, where I did get involved in recruiting an oncologist. And these things are important because it creates a dialogue of them opening different avenues for you. Like, can a patient get a little pamphlet when they're getting discharged saying, hey, here's a number you can call if you want to discuss your pathology with somebody? Will that pamphlet change the culture of our entire institution, in our entire department? It's very possible. And these are just ideas that, you know, I've been throwing around. But I challenge all of you, and you're all very smart, to think of ways that you could kind of relate yourself back into other specialties.
Thank you. There is another question I see online from our viewer, Emmanuel. So who wants to know, what were the measures done to protect the pathologist and medical students' mental health? As we know that it's a very emotional, physical, but also a very taxing mental challenge.
So actually, we have that's a great question, Emmanuel, and it's something I'm actually working on right now. The Department of Psychiatry at NYU and Psychology have offered to have group meetings with Dr. Thies, myself, and all the other 18 pathologists who serve this role to discuss our experiences. And the emotional side should definitely never be underestimated. I personally went through a lot of emotions dealing with, and we didn't even get into the details of these phone calls, but many of them were difficult. And that is it had a lasting effect on my career. My father, who's a pediatrician, told me that you're not going to be the same pathologist after doing this. And you know, at the time, it didn't really make sense to me, but it definitely makes sense to me now. And we are going to have some sessions where the 20 pathologists are going to meet with psychiatry and psychology, not for them to diagnose us with any kind of post-traumatic disorder, but just to discuss and consolidate and close this kind of episode that we had for 7 weeks. And Neil, do you have anything to add to this?
You know, I am concerned about that aspect. I was concerned during, because as I've expressed to you, I think one thing we haven't trained well or maintained our training in is how to have appropriate boundaries between us and our patients. And a lot of us got very attached, and the families got very attached to us in some circumstances. And there are ways for that to be appropriate and helpful and professional, but it's tricky. And I think that that was a trap that's important for us to process and learn from. But I'm also generally concerned that if this is an issue for us, the issue for the clinicians who were on the floors is orders of magnitude greater. And my liver team came off of their COVID service really shattered in many ways. And it's been hard for me to find ways to help them and find resources available other than saying, go see a therapist. I think that the most useful thing in this circumstance isn't actually, you know, I'm a huge fan of therapy and analysis and psychopharm stuff if you need it. I've benefited for years from all of it. But to some extent, it's talking to other people who have had the experience. Back in the AIDS days that you alluded to before, it was really important for us you know, I came of age as a gay man and as a doctor at the same time during those times. And the healing of the clinical situations often came from talking to the other people who were in it with me. And it's not even formal group therapy. It's simply knowing you share this experience that you can't share with anybody else. A lot of the clinicians coming off the floors talked about their families going home, and they hadn't seen their families because it wasn't safe for them to go home. And when it was safe for them to go home, their families had no idea what they had been through and couldn't really understand it. It's like coming back from war. And sometimes I think the most important thing is to just speak with the other people who you shared it with. And that was something you instinctively put together, Syed, when we came together. There were always opportunities for our team to speak to each other. And I think that's what helped us all cope to the degree that we did well, very well, I think. But that concerns me for the larger clinicians in the institution. I'm not sure that the institution I've not heard of any institution that's really stepped up to deal with the potential for PTSD, serious PTSD from these experiences. And not just for the clinicians, the janitors on the floors, the translators on the floors, the social workers, everyone who lived on planet COVID during that time, to the exclusion of everything else, I'm concerned about.
Thank you. We have a viewer from Quebec who wants to know, how is New York City managing with old retirement homes, which is becoming a big crisis in Quebec and Montreal?
So Dr. Hockman had to go because her daughter, or her kid, has a graduation, sign of the times, these virtual graduations. So she had to log in at 10:30. I don't want to answer without knowing all the details. But I know that this is a big social issue in New York, and there were a bunch of regulations that had happened during the time of COVID-19, which then got changed because what was happening is that the retirement homes, the personnel were inadequate. There were issues with people getting discharged and then being sent to retirement homes as an intermediary place of quarantine, which is totally odd by any means. But that's about the extent to which I know. I wish I could answer more thoroughly, but I don't. Neil, maybe, unless you know something more.
Yeah, because it's an issue for several members of my family in the New York area, so I've been immersed and juggling it. And I think it's basically what it's been globally. There are spots that have managed it well, and then there are disasters where there's been death after death after death. It's highly variable, but it's mostly been grim. But I think that that's true for most societies that put their elders in aggregated facilities the way our culture does. I'm not sure anyone has managed to avoid that, even where they were focusing on it, like in some Scandinavian countries. I think place by place, some did better, some did worse, but in general, it's been horrifying.
Right. So, I mean, in continuation with how the pathologists are helping patients, here's a comment basically from Paula in Brazil. So she says, I did my training in the US, and when I came back to Brazil, I had to get used to talking to patients, but I initially felt quite insecure, but right now it has become pretty normal to me. And there are a couple of comments that I wanted to read out. And one of our viewers from, her name is Lean, I guess. Thank you for bringing up mental health and the role of the pathologist as the not just silent members of the medical team. That's good to hear. And there's another comment from Celestine. So I would say it's what a great initiative. I love how it not only helps pathologists connect with the patients, but also with other physicians in clinical specialties, help us understand all each other better. I think these are the questions. Anything that one of you want to add, you're most welcome.
I just want to thank you guys at Pathcast again for letting us discuss this. I think it's not the most comfortable topic for most of us, but Dr. Thies and I are very happy to be here talking about it. And I think that we just need to open different dialogues sometimes to see what's there. And like the art forensics and the first slide that I showed, there are some things that we just don't know until we actually go and see them or become aware of them. And I just want to encourage everybody to keep their radars on and don't run from new experiences. Dr. Thies, if you want to say anything before we close up.
No, I'm just grateful, as I keep saying, and grateful to Rafat and Emilio for making this opportunity available.
Thank you so much for.
Oh, and to plug my next Pathcast.
Yes. Thank you all
When
for
is
this. I will get back to you once I check the calendar.
Okay, I think it's July 14th. Okay.
Thank you all for discussing something so relevant, and that pathologists are playing such a unique role at these very difficult times, and which is an eye-opener for all of us, so that we can come out of our comfort zone and really make ourselves relevant and do something the best way. As a physician, we are a physician at the end of the day, how best we can help the patients. Of course, that's what is our main goal. And I'm lucky to have learned from Dr. Tees that one key thing that always communicate with your colleague on the other side. And in my first job, one thing I thought that would be the first thing I would do is to pick up the phone and talk to the surgeon or the endoscopist. And in 2 years, I think that has helped me so much and helped even formulate my report better. So thanks to Dr. Tees and all my teachers for bringing this up, which is something so important that we need to learn to communicate. And Dr. Tees is one of the pioneers, I would say, that who knows how to communicate with people. So thank you so much again. And you all will be very happy to hear that we had at least hundreds of viewers from so many different countries. I could keep track of 20 countries that viewers were from. People were from Libya, Philippines, Nepal, Dominican Republic, Indonesia, Ecuador, Brazil, Bolivia, to name a few. And thanks again for your time. And I would just like to mention here that our next podcast is coming up on Tuesday. That would be at 8 a.m. Eastern time. And interestingly, that will also be a panel discussion, but it is on cytology, in which we will have 3 speakers, Dr. Zubair Baloch, then Dr. Jalal Jalali, and Dr. Norhe Vergara, so who are from University of Pennsylvania, and they will be discussing interesting cases, raising important questions in everyday practice of cytopathology. Hope to see you all there. And as always, please feel free to follow our Facebook page and like our page and subscribe to our YouTube channel. And please subscribe to our newsletter as well, so that you stay connected to all the upcoming lectures. And thanks for all your support. And thank you, Dr. Hoda, Dr. Hockman, and Dr. Tees once again. We appreciate it.
Thank you.
Thanks.